Nikhil, thank you so much for that. I would request all the moderators, coordinators, honorable chairpersons, honorable speakers to please join in as panelists so that we can kickstart the very first session, that is from 14 to 16:30 CET. Ladies and gentlemen, we're all waiting for you to join us and to have a wonderful, insightful session ahead. We'll be starting in next 2 minutes, as it is 6:46 according to IST. We're waiting for a couple of minutes. Once everyone joins in, we'll be starting off with the session. Thank you.
Has Dr. Meeta joined in? Dr. Meeta, please join in and accept as a panelist. You would be able to see an option. In the meanwhile, we have Dr. Anjali Miglani ma'am with us. Hello, ma'am.
Yeah, hi. Actually, Dr. Meeta is still in the attendee. She is struggling to get in.
Yeah, we have sent her a request, but she needs to accept it. Only then she'll be able to join in as a panelist as you did. So she's not accepting the request, ma'am. And she is going to be introducing the topic for all of us. So would it be possible for you to introduce the topic, and can we take this forward, ma'am, please?
I'll do that. No worries.
Sure. In the meanwhile, I would just like to introduce our moderator with us. We've got Dr. Anjali Miglani, who's the Chief Medical Officer, NFSG, Directorate of Ayush, Government of NCT of Delhi. And we've got Dr. Raj Kumar Manchanda sir, who needs no introduction. Over to Raj Kumar Manchanda sir to introduce the topic.
So, thank you very much. So in our first session, we'll be having 5 speakers talking about the experiences of acute and long COVID-19 in different organizations. So this is going to give us an overview of what is going on within homeopathic sector as regard COVID-19 pandemic is concerned. So with these words, thank you very much.
Thank you very much, sir. We have our first speaker, Dr. Anil Khurana sir with us. Dr. Anil Khurana sir, could you please switch on your camera? Yes. And also unmute yourself. Yes. Thank you.
Yes. Good evening. Good morning to other part of the world. Am I audible?
Yes, sir, you're audible. You'll be getting 30 minutes, sir. Would you be kind enough to please share your screen?
So I'll be sharing my screen now.
Yes, sir, please. The total time allotted is 30 minutes. In case if we finish early, we can have some question and answers right away, or we could have question and answers after all the speakers have spoken in this session.
I hope my screen is visible.
Yes, sir, your screen is visible. You can get started, sir.
Okay. So I am Dr. Anil Khurana, Director General Research in Central Council for Research in Homeopathy, India. And I'll be talking about the COVID-19 and homeopathy, our Indian perspective, how we have taken this into consideration while from the very beginning of the pandemic. So here, we know the homeopathy epidemic has a long history. The preventive role of homeopathy in epidemic diseases is well known and reportedly being used for prevention during the epidemics of cholera, Spanish influenza, yellow fever, scarlet fever, diphtheria, typhoid, etc. And there's an anecdotal evidence that homeopathy was successful during the Spanish flu epidemic of 1918 to 1919, in which at least 20 million people died worldwide and more than 500,000 in the United States alone. According to the historian Julian Winston, the death rates for patients treated with homeopathy were 1 to 2%, compared with 30 to 60% mortality for those treated by conventional medicine. So when this pandemic started, just before that, in January 2020, we were having a conference here, international conference by HPWWC, and we were talking about the role of homeopathy in epidemics. And at that time, during my address in that conference, I spoke about pneumonia cases which are being reported in China at that time. This was in the first week of January itself. Although there was no case reported in India by that time. But there was some kind of a warning which was coming from one city that an epidemic has started. But soon it took over the form of pandemic. And in January end, we had a scientific advisory board meeting when it was going on. And we started discussing on the directions from Ministry of Ayush, whether we can offer anything for this upcoming pandemic. And our SAB, Scientific Advisory Board, looked into the information available on the symptomatology from various sources, which was published in Lancet Journal and other case studies which were published at that time. And arsenic album considered to be as the one of the genus Eventemus rebedi, which was advised by Central Council for Research in Homeopathy on the recommendation of Scientific Advisory Board to the Ministry of Ayush, which issued this advisory after considering all aspects and taking into consideration that the principle of genus Eventemicus has proven to be beneficial to the society in the past in many such epidemics. So this advisory was issued on 6th March 2020. Arsenic 30 was recommended as a prophylactic medicine as a genus epidemicus to be consumed by the public, and this advisory was widely circulated to all the state chief secretaries and state union territories in India. And there was a notification which was also issued in 2nd April for interdisciplinary Ayush research and development task force, which was constituted on 2nd April. The task force approved many proposals of homeopathy through crowdsourcing, which were recommended by screening committee, and all homeopathic such proposals were screened by our Central Council for Research in Homeopathy. And such proposals were further recommended by the task force to take up to the research studies. So this notification was issued, and there was specific guidelines were there mentioned that this notification guidelines for scientific research, like each research study should have a clear ethical clearance. They have to follow GCP guidelines, appropriate sample size, history with clinical trial registry of India, etc. So these, on the basis of this, the research proposals were invited, and Central Council also start looking. And we also developed a guidelines for homeopathy practitioners for COVID-19 on the basis of our literature, which can cover the drugs which are covering the symptomatology of COVID-19, and these were recommended for general practitioners if they face such cases in their practice in hospital settings, healthcare settings. Such advisories were further issued by many other state and many provinces, even many organizations like the Central Railways in Mumbai, Eastern Railways, NCT Delhi, and many other such advices were further followed by many other state provinces, and these were taken up by the people. Even Supreme Court upheld the advisory of Ministry of Ayush for use by homeopathic practitioners at one point of time. And CCRH also published first journal in April to June issue of 2020, where we discussed the various aspects surrounding this COVID-19 and all the archives information which we had for past such experiences in the other epidemics which were dealt by CCRH and other parts of the world. Such a review was also published here for taking care of such pandemic in the future. So from the very beginning, as soon as this notification was issued, where we could be allowed to take up such research studies, at the COVID treatment center. So we had a pragmatic plan for homeopathic intervention. And so the first, after distribution of arsenic album, which was recommended as a prophylactic medicine on the homeopathic side, the unexposed asymptomatic population, which was at risk, we targeted that population for prophylactic distribution. We had a big study taken up. Various efforts were taken up by many organizations, colleges. So I will be coming in details to each and every effort which was taken up by us in collaboration with other organizations. Another aspect was exposed asymptomatic. At the earlier stage, there was a policy that all persons who had come in contact with the COVID positive needs to be quarantined in a facility. These facilities were either COVID care hospitals or many other such places where these persons were kept for a observation of at least 2 weeks. If they developed symptoms, they were given treatment or they were given some kind of a other usual care. The COVID-19 positive asymptomatic cases, there are, as per the clinical picture, many such patients who had became COVID positive, or almost 80% were reporting as asymptomatic. So we did took up such a study for asymptomatic patients also. And then with mild COVID-19 symptoms in a COVID care center, with moderate to severe COVID-19 symptoms, it was taken up as adjuvant to the standard treatment. And it was taken in dedicated COVID treatment centers, which are allowed by those authorities to take up such homeopathic trials, and then post COVID-19 management, which we are now have started. This was the first information which we collected from various sources. We requested all homeopathic medical colleges throughout the country to distribute this arsenic album 30. And this arsenic album distributed was, if you see the data here, almost 17.1 million persons received this homeopathic arsenic album 30 through over 109 homeopathic colleges, which was, and this is the map which shows the highest affected areas, Maharashtra, Gujarat, and other places. And this data was further analyzed by us on a structured platform, where we analyzed that information on that manner that arsenic album was the most frequent choice of intervention, even found in a Sanjeevani, Ayush Sanjeevani. This was an app which was developed by Ministry of Ayush, where the people were invited to upload their experiences when they took up any Ayush intervention. And in this particular app, a huge data of more than, say, about more than 10 million data was accumulated there. And among other homeopathic medicines, people also use Bryonia, Rustox, Belladonna, Gelsemium, and as per the recommendation of the practitioner at that time. So these are different kind of study designs of the study, which were taken up at COVID-19. Like the type of study, there was 42% were almost prophylactic studies, treatment studies of 53%, 5% were other, which were of preclinical or immunological aspects surrounding many medicines. A prophylactic trial design was, there was 63 which were randomized controlled trials, 37% were observation studies. And these are treatment trial design, again 30% were observation studies and 70% were randomized control. These are the studies which are taken up by CCRH. There were 18 trials which we took up. 4 were preclinical in the laboratory model studies, 7 were prophylactic, and 7 were treatment studies. These are the prophylactic trial medicines which are taken up at various times, which are there, and the CTRI. This is data from the CTRI. Different medicines have been taken up for trial as a prophylactic medicine. Another treatment trial, these were the medicines. There were certain trials using single medicine like Zincum vereticum, even Kadamba also. These different medicines were also used in some of the trials which are registered at Clinical Trial Registry of India. And according to severity of diseases, there were many trials which were taken on asymptomatic, symptomatic, mild, moderate to, and moderate to severe. These are some of the teams which had takes glimpses of those teams which are going door to door to distribute arsenic album as a prophylactic medicine as well as under the tertiary care setup also. So this was the first information which we actually collected from the almost 109 colleges who contributed to this. We analyzed the information about 0.67 million persons who had actually completed 3 weeks post consumption, and they were analyzed. We collected this information on a structured format from these people about their whether they had any developed any symptoms if they are after taking arsenic album 30. And if you could see at the table below, almost only COVID-19 population who was suspected or confirmed were only 0.32% who consumed arsenic album 30. Only 2 deaths were reported. Out of this, laboratory confirmed COVID-19 cases, only 127. So non-suspected population was almost 99.6% from this huge data which we collected from the various sources. And incidence rate of COVID-19 in the population, if you can see that at that time, in spite of that, there was a gradual rise from February to August, but in a population who were receiving arsenic album, the graph was going down in that particular population. And even out of this population, we analyze the information about the high risk group. Either they were having some kind of a comorbidities or high risk suspected confirmed population. And we analyze that almost percent of such population were protected were 98.14%. So prophylaxis against COVID-19 for population was also an effort with the Delhi government. Dr. Manchanda facilitated that kind of prophylactic distribution among the population which was residing in Delhi prisons. And these were the inmates there. They were given homeopathic medicine and they were followed up at different time points like June, July, and then August. And we could see that after 3 weeks of follow-up, by coming to July and August, there was no such case in these Delhi prisons which were detected COVID positive. Association between prophylactic Ayush intervention and disease outcome in COVID-19 positive patients. We also tried to find out a retrospective cohort study whether the persons who were actually COVID positive and discharged from the hospitals, whether they had taken any prophylaxis, Ayush prophylaxis before they became COVID-19 positive. And we tried to find out any correlation, whether it has altered the clinical course of such patients. And we could find out that the only 10.4% had gone into moderate or severe cases who actually consumed Ayush prophylaxis. And this data actually include all Ayush intervention, Ayurveda, Yoga, Unani, Siddha, and Homeopathy. If you can see that out of this 5,000 such sample, almost 56.81% of this system-wise breakup, they received homeopathic intervention. Another study which we actually now started taking up proper prophylactic clinical trials through a CTRA registered and ethically approved our protocol. And this was a study which was done in Delhi in the very initial phase. And this was taken up from May to August. And the study size, there were 11 containment zones of Delhi in a high risk population. The analysis was done for almost 10,180 intervention population, 6,590 and control 3,590 under the control who did not receive any intervention. And population was comparable at baseline with respect to age, gender, occupation, and education. Similarly, use of safety measures like use of golden ring, use of mask, sanitizer was also more prevalent in non-intervention cohort. And before intervention confirmed, that although there was a increased risk in the treatment group, almost 1.77% as compared to 0.25% in the control population. And we could find out that the overall protective effect of arsenic album was 83.45%, as compared to the control group. And adjusted protective effect of arsenic aluminum, taking into consideration all confounders like the people who are taking golden milk or taking into care that they were taking all kind of precautions. Still, the adjusted protective effect came out to be 77% in the population who received homeopathic intervention, arsenic aluminum 30. Another study, that was only Delhi based, then we took up a multi-centric study, which has a pan-India study in many study sites like containment zones of Delhi, Chennai, Mumbai, Kolkata, Machilipatnam, Hyderabad, Surat. And again, the sample size was of 32,301, intervention 22,753, and control 9,548. So this was the study which was taken up with a control population as a pan-India. And again, here we could find out that there was a statistically insignificant difference between the two groups and at the baseline. And the results we could analyze after that the reported confirmed suspected COVID-19 cases in treatment group was reduced from 0.61% to only 0.07% as compared to the control group, where it was decreased from 0.86% to 0.36%. And incidence rate in intervention cohort per 10,000 person week is 6.04, while for non-intervention cohort it is 29.78. So 0.5% cases with comorbidity were COVID-19 in medicine cohort, whereas in control cohort it was 1.2%. So the overall protective effect of arsenic aluminum was 80.22%, and adjusted protective effect of arsenic aluminum again in the pan-India study came out to be 79.5%. So the possible interpretation of the study's results in the prophylactic trials were that effect of arsenic aluminum was interpreted from 3 studies conducted to different setups, like 2 studies high-risk population containment zones and 1 in general population in different parts of the country. The results are consistent over different time period and among population of different concerns and health practices. The medicine consumed group has less clinical COVID-19 case in comparison to the control group. This may be due to decrease in infection rate, or medicine is able to decrease the clinical case and aiding recovery without any sequelae. Coming to the treatment studies, we had different kind of trials which were taken up as a effectiveness of individualized homeopathic treatment add-on to the standard treatment in COVID-19 infection. This was one study which was taken up at Chayu Hospital, a tertiary care setup in Bhopal, one of the province in Madhya Pradesh. And the patient, we could conclude after the study that the patient in medicine group got relieved of symptom 2 days earlier, and there was 61% decrease in CRP level in add-on treatment group. However, it was only 21% decrease as was observed in standard care alone. So there, the results are quite highly statistically significant. Another study which took up on asymptomatic population, again in Bhopal, in a COVID care center. This was a government homeopathic medical college, Bhopal, and the target sample was 200 asymptomatic, and the intervention was arsenic aluminum, camphor, Brainia alba, and placebo. And we could have a good achievement of this sample size. Even IgG antibodies were tested later on. However, there were limitations of the study that as per the prevalent guidelines drawn by the provincial government, homeopathic intervention could only be given along with the standard care. So most of these patients were receiving either SCQ and other supplements which might have contributed a large proportion of any treatment effect, although within 10 days, the effect of the treatment on arsenic and Brainia was almost equal effect up to 10th day. The RT-PCR became negative in most of such patients up to the 10th day. And AIMS Jhajjar, which was a study, it is another big hospital near Delhi, where we could take up this study to evaluate the effect of homeopathic treatment when given as adjuvant in moderate and severe cases of COVID-19. It is primary objective of time to convert RT-PCR COVID-19 status to negative, and the comparative change in the clinical condition assessed through the Coase scale of WHO at day 2, day 7, day 14, and day 28, and the patient reported major years of medical outcome profile, MIMOP scale, and laboratory parameters. And then we could gather out of this study that the mortality was quite significantly low in homeopathic intervention group, and the recovery was again faster in homeopathic intervention arm. Although these studies will be presented by our scientists in different forums here in this LMHI in detailed manner. And another study which was taken up at St. George Hospital, at JJ Hospital in Maharashtra, again similar kind of a study, a single blind randomized controlled study using an intention to treat protocol study was conducted at Government Maharashtra, and the total 129 confirmed COVID-19 positive cases were enrolled in the study. Among them, 57 severe and 8 moderate cases enrolled in control medicine group, and 55 severe and 9 control cases were enrolled in the placebo group. Both the groups received the standard line of treatment as per institutional management protocol, and the experimental group received homeopathy therapy as add-on to the standard care. Again, the endpoint, we could see that total stay in hospital in the group 1 was on 12.89 days as compared to 14.92 days in the control group. If I can say about the another opportunity which we received in Gujarat was that they allowed homeopathic treatment at the even at the mild stage in civil hospitals, and we had a chance to collaborate with them. We provided a structured format to capture information of all patients who are treated in civil hospitals by homeopathic intervention. And this was a time when we received a data of 2,581 such cases treated in civil hospitals, and the study was quite impressive in the sense that the data which we could collect and analyze, that 81.8% patients of these COVID, they were relieved by day 7, they were discharged by day 7, and most of the patients, including this, all patients were relieved by day 15. Only 0.2% had gone beyond day 15 and 16. Out of this, the whole 2,581 cases, only there were 3 cases who actually required intensive care, and they were referred there. This is how the data which we have now collected at this point of time. And so I acknowledge all research scientists of CCRH, principals and faculties of homeopathic colleges, authorities in Delhi prisons, Maharashtra police and private practitioners contributing in the initiatives of council and collaboration with CCRH. Our special thanks to authorities of Ministry of Ayush, Task Force for COVID for facilitating the studies, and other state authorities, even local health authorities who have allowed us to do that. So thank you all for giving me opportunity, the organizers, to share our experiences of COVID-19 in India under CCRH. With the request to listen to please detailed presentation on studies which will follow in different sessions by our research scientists, the investigators who actually worked in these studies. Thank you so much.
Thank you so much, sir, for that insightful session and a very good talk. Now, I would request all the delegates to please put in their questions in the Q&A section. If anybody has any question, can put it in the Q&A section and will be addressed. With the discretion of our honorable chairpersons, I would request that we should take the Q&A round towards the end. Will that be fine, sir? Our honorable chairperson?
I think it's okay.
Thank you. Thank you so much, sir. I would request everyone to please put in their questions at the Q&A so that we can address it towards the end. Thank you. Moving on, I would now love to invite Honorable Dr. Alex Turner, who's from United Kingdom, to present a talk on the topic, a fresh look at the concept of genus epidemicis in the light of the findings from the Clifocal project. The talk will be of 30 minutes, and I would request Honorable Dr. Alexander Turner to please turn on his camera, switch on his microphone, and share his screen to please take over. Thank you, sir. Over to you.
Can you hear me?
Absolutely. Perfectly.
Great. Thank you very much to the organizers for inviting me to present today. It's a great honor to be so high in the lineup for today and to follow Dr. Anil, whose presentation and the breadth of the material presented is difficult to follow. but I will do my best to follow in his footsteps and tell you about the findings we've been doing about in the context of COVID through the Clinical project. So can you see my screen? No, you cannot.
Please try sharing your screen. Have you shared your screen?
Yeah.
Yes.
Is that okay now?
Yes, it's visible perfectly. Thank you.
Sorry about that. So yes, it's great to be able to present today on this amazing conference. So many speakers, and here we are. So we also with Yvonne Falk, Dr. Yvonne Falk,
Alex, you are not in full screen.
And not in full screen.
Yeah, you're not in full screen.
We are perfectly able to see Sir's screen.
All right.
Raj, we can't hear you, Raj. Okay, can you see my full screen?
Yes, we can see your full screen perfectly.
Is that okay, Yvonne?
Yes, I hope it's okay for you, Doctor.
I can see your next slides.
Yes, okay, then you're not seeing the right screen.
That one is at the bottom of the screen, I think. So that's the reason you're able to see that. Have you joined in from your mobile phone, Doctor?
No. This is not the right.
Yeah, it works now. Yeah, perfect.
Okay.
Perfect.
Okay. Thank you, Yvonne, for catching that. So I was also going to say this is work done with Yvonne, Dr. Falk, also present, who just told us about the slides, and Dr. Robert van Hasselen, who's probably in the audience. And so we also got involved in the clinical in COVID at the beginning of the pandemic. So we're talking 2000, April 2000, when we started to look at all this, and we saw the need to have more data gathered from our European colleagues in terms of what they were seeing. So what was being treated in Europe in particular and around the world, and what were the pictures that were coming out of the patients. What compared to what Dr. Anil presented just before, we were very limited in the type of study we were able to do. As you can imagine, any idea of a trial of homeopathy against COVID in Europe was not even thinkable at the time. And so this is what then we came up with as an idea to do something. So the idea really also was to use Clinical. So Clinical is a platform for case registry, and it's been around for a while, but in this pandemic, it was reborn as the Clinical COVID-19 support project. And really, the idea was to look at what symptoms and what homeopaths are doing as adjunctive treatment to homeopathy, because of course, that's what we could do at the time. So today, I don't want to spend too much time on the results from the big kind of Clinical worldwide. I want to tell you more about what we found specifically regarding the genus Epidemicus, because that's like new and just about to be published. So to tell you about that, so the first thing is that, yeah, as I just mentioned, we had limitations with the study itself as a huge international longitudinal epidemiological study. It had no control group, many confounding factors. What other treatments were the patients having? Many potential biases, were the homeopaths themselves biased in different ways. So these are things that we knew we were going to face, but yet we wanted to be able to collect that data and ask some questions that would be useful for the community as a whole. And the genus epidemicus is one of these concepts. So to show you a bit about what the data looks like, kind of the worldwide data we were able to collect, or that the platform collects, the platform is a huge effort. Nearly 200 organizations came together. We will show more about that towards the end, but it was a huge worldwide effort to collect all this data. Now, the platform currently has close to 1,200 cases in it, and that corresponds to about more than 3,000 consultations and 1,600 prescriptions. Now, 42% of the prescriptions in the database currently do not have rubrics, and that just indicates that the homeopaths who entered the case probably used a symptomatic or epidemic prescription and prescribed very quickly, or just didn't provide us with rubrics. The problem with that for us is that we will not be able to do the type of analysis I'm going to show you now in terms of rubrics, but we can look at what the remedy prescribed were, for example. So in terms of over time, what we see is that we can look per country, and we see that China had a very large first peak, whereas India, it's more later on, towards the autumn of 2020. The States, it's more like different waves of the epidemic we can follow. And we can see that Italy actually started earlier than anybody else. And so we can see that in time through these time courses in the data. In terms of demographics of the populations, there's no surprise there. Slightly more female patients. The average age is 41, which is relatively young for the COVID-related population. In terms of cases in the database, 31% still coming from China. So most cases are from the team in China, Hong Kong, which I will be talking mostly about in the next few slides. Then followed quite a bit of data coming from India, and more data is coming from India at the moment. And also we have quite a lot of data coming from the States. Now, in terms of severity, you will not be surprised that most of these cases were mild. That's very characteristic of just of the availability of what the homeopaths, what type of homeopath of patients, your kind of standard homeopath family doctor would see around the world. The few more critical cases, quite a few came from India. So now I want to concentrate on the data from China that gives us an insight into the notion of a genus epidemicus, which has relevance for the whole kind of COVID pandemic. So this data is interesting because it's close to 360 cases collected by 20 practitioners. It's 766 consultations, and that corresponds to 363 prescription episodes. So we define a prescription episode by a prescription of a remedy, and that the remedy is not changed. Even if the potency of the remedy might be changed, then we still consider that if it's the same remedy, we call that a prescription episode. One particularity of this data set is also that 97% of the cases were confirmed through PCR. So very high validity here in terms of confirming COVID. Another particularity of this data is that the symptoms were gathered using a questionnaire with 150 questions on it, plus additional kind of free items you could add. So that amounted to nearly 190 possible items. That was the possible rubrics that we used. Only about 60 of them were used more than 10 times. So 60 rubrics were used mostly, and those are the ones that we concentrate on. Another interesting aspect of this data is that on average, the median number of rubrics used per case, per prescription, was 22, which is quite high compared to the rest of the world, which used 4 to 5 rubrics per case. So this gives us an interesting opportunity to investigate the concept of genus epidemicus. So I'm sure I'm not going to teach anybody here about the concept, but just to rehash a bit, the homeopathy finds the notion of genus epidemicus as the combined symptom of a large group of people affected by a similar disease or the same disease, and that then also would describe the remedy associated with that pandemic. So then the question we came up with was, well, is there really a unique symptom picture in COVID that would then describe a unique remedy covering all symptoms? Is there this idea of a perfect remedy that would cover all aspects of this pandemic? And this has been a big discussion, or was a big discussion at the beginning of the pandemic, and we wanted to look at it. So in order to address that, we use a technique called cluster analysis. And this is used to extract features out of very large data sets. For example, like Facebook data uses this type of analysis all the time to categorize types of customers. And so we used it to extract similarities between sets of rubrics, so to find out what kind of families of rubrics and to find out what those pictures were coming out of the data. So rubric pictures, symptomatic pictures. And so we used a technique called principal component analysis, which is a technique that enables us to do dimensionality reduction. And so if you remember, I said we had 60 rubrics to work from. And so if you do that, then you can reduce your, 60 rubrics, 60 dimensional space, you cannot visualize. But you can use such a technique to reduce your data space in a way that you can then visualize it. So if you imagine on the left a very complex data set, and that might be many dimensional, we can then project it, say, in a 2-dimensional space where we can look at it and it's meaningful. And in this case, we can see that there are 4 clusters that are meaningfully present. And so that's one technique. And the other technique is called k-means. K-means is a algorithm that automatically assigns clusters. So if you have a data set that looks like the one on the left, where you could kind of make out 3 clusters, k-means will assign them for you automatically. So and give a score for that, and it's so that we can automatically find out what is the right number of clusters and also score that. And so coming back to the genus epidemicus, if we hypothesize that there is a single genus epidemicus, that is, there's one overall picture, and so one then overall set of symptoms that describes the population, we would then imagine that representing these rubrics would be something like on the right, where you have a strong center where there are all the kind of common rubrics, common cases, and then each case kind of varies slightly from this strong center. So variations around the theme, this is what we would expect, and this is how we would expect it would look like. And so now if we look at actually what happened and if we look at our data, then what we see is that it doesn't look the same at all. We see that there are in orange and in blue, bottom and top, 2 large clusters, quite prominent clusters that that are very, very distinct, and you can do some mathematics to look at the probability of this being by chance, and it's incredibly small. So these are really two clusters that we see when we do this type of analysis. And another way of so as I said, you can also score these clusters, and the number of clusters you can score, and 2 seems to be the most favored number of clusters. Also, although we could also see on the right potentially another cluster, which we can also see if we look at the data this way. And in this way, we just looked at, so we reduced our space into 2 dimensions, so we can look at it, and we superimposed on it with the colors the prescriptions that were actually given to the patients. So the colors are what was done, what was prescribed, and each point is a representation of a prescription of the rubrics used during a prescription. And what you can see is that on the left, you have a very strong cluster of cases, of prescriptions in blue, and they correspond overwhelmingly to prescriptions of gelsemium. So, and on the right, you have a strong, again, a strong cluster of rubrics of prescriptions, and they also correspond to bryonia. And what we see is that if you look at the smaller remedies like phosphorus, they also appear to cluster in their own little cluster, and arsenicum at the top in red, we see also forming smaller clusters. Potentially, these clusters are too small for us to verify, because we just don't have enough cases of these remedies in this particular data set. But we can imagine that they would form their own well-defined clusters if we had more data. And so with that, what we see is that that we had at least 2 clusters, potentially more, but two very clear clusters coming out of the data. These were symptoms gathered through a questionnaire, so we can assume there was very little interference from the practitioner. That's not like the practitioner saw a gelsemium case and influenced somehow the questionnaire. So we have a very solid foundation purely from the symptomatic. So we can say quite confidently that the Chinese patients during the COVID did not present a single unique symptom picture that would be representative of the COVID pandemic. And so there would not be then one single Janus epidermis remedy. In this particular case, we see at least 2, and there are indications, of course, that around the world more remedies were prescribed and probably were also very justified along the same lines. That is, they are actually symptomatically very distinct presentations of the disease. Although they are the same disease, patients come and present it very distinctly, very much in the way that homeopaths understand this notion of individualization. And so what would happen if you were to simply combine all the symptoms, which is an approach that's often taken. And if you did that, you would find the gelsemium, which is the prevalent remedy, but you would completely miss out on bryonia as actually a very relevant 20% of the cases being bryonia in this data set. So you would miss out on bryonia being an extremely relevant remedy if you just combine all the symptoms together and looked at a repertorization. So this is where the strength of the clustering analysis comes through. This only such a clustering analysis is able to separate them out and really show that the Brownia cluster is actually very meaningful. And now, if we look at rubrics that actually are not common but differentiate, then you have these rubrics coming through. And what's interesting when you think about differentiating rubrics is that this is what homeopaths do on a daily basis when they have a case and they see like different pictures within the case. Then they look for these differentiating rubrics that help them to go towards one remedy or the other. And so we can actually find those differentiating rubrics from all the type of analysis I showed. And that corresponds very much to the type of work a standard homeopath does every day, is this kind of pattern recognition through differentiating the different remedies. A particular peculiarity of this data set from China is the symptom head pain ameliorated by profuse urination. That is very unique symptom that came out of the questionnaire. And so we investigated a bit, and it is absent in the rest of the world data. So this particular symptom was not reported in the rest of the world, but also it was not reported in previous uses of the questionnaire in Hong Kong. And so it's just something that seems to be very specific to that population at that time during the COVID pandemic. And so we're quite curious whether other symptoms around the world also came up through that are quite weird. And so with that, I want to tell you then about what we're doing next. Yvonne is still actively working on modeling. And so the idea here is, can we find a mathematical way to describe the relationship between the symptom pictures that I talked about and the prescription. And if we can do that reliably, so that is, if we can reliably predict a remedy that would speed up recovery, if we can do that reliably, then we also strengthen the idea that homeopaths, when they do that, when they prescribe a remedy, are not doing something that is purely random. They're actually following a pattern that corresponds to a reality that it increases the patient's recovery speed. So this is something that's ongoing. This is kind of mathematical analysis. Another piece of work we're involved in is the rest of the world, where we're looking at also all the prescriptions and the rubrics there, and to find out what the clusters there. So that's ongoing. So just to finalize my bit, I've told you very much everything. There is not a single remedy for the genius epidemicus, and we found that the use of questionnaires was very interesting in allowing us this type of analysis, which is when homeopath is free to put any rubric. We see that they use a vast number of rubrics, which is much harder for us to use to do such analysis. So as I said, the coming up are the modeling and the rest of the world data. So with that, I'm going to pass on to Yvonne, who has a few things to say about what's coming up next as well. Oh yeah, and sorry, and this what I just talked about has just gone to publication and is under review right now. So
thank you, Alex. Thank you. And as you can imagine, although the critical platform has been there for quite some time, but in these 2 years, it has tried a new way of data collection, which acts as a kind of case registry platform. And the COVID-19 has given the platform the first chance to test it to be like a case registry project. But of course, it would not be the only one. And as many of you would agree that long COVID would be another opportunity for us to research on homeopathy. And so the second platform that has been launched was the long COVID platform, and it was officially launched in October this year. Although there is still not a really definite definition of long COVID, because the definition varies between different associations, organizations, and different researchers. But the inclusion criteria that we used in the clinical COVID, long COVID platform was the persisting symptoms for more than 8 weeks after the acute COVID-19, and it is not explained by another diagnosis. And the platform has, from the experience that we got in the acute COVID, this time we have made some adjustment on the method of data collection. There are 3 levels of symptom collection right now. First, it is from a checklist. And now in the platform, when you click into the long COVID data input, then you would see a 24-item checklist for common long COVID symptoms with intensity. So these 24 items are commonly reported long COVID symptoms, and we arrange it according to the organization of homeopaths school of thoughts. And we hope that it can facilitate the input by just clicking on the intensity. Then we can understand how what are those kind of patients that we are seeing as homeopaths. And then the second way of data collection, symptom collection, is by free rubrics entry. So you can just copy and paste the rubrics from your software, and then you can enter into the platform, and then with a very visible way, you can click on the intensity of the rubrics. And then number 3 is a free text region. This free text region is for those symptoms which you think cannot be properly input from the checklist, and it cannot be properly represented by an existing rubrics. Then this third way is the way that you should enter your data in. And at the back end, we would keep on checking this free text region and to see if there's anything that we can update on the checklist or in the rubrics entry region. So the COVID and the long COVID is just a very fast 2 testing stone, but we can see that the clinical platform is moving from the more generic approach, which is like all pathology kind of data collection. We are moving towards the direction of modular indication. So we collect data through a design of targeted case registry kind of setting. In this way, we can design the module-specific data collecting form with specific diagnostic accuracy, onset, severity, follow-up time, outcome measurement. In this way, we can minimize the heterogeneity and noises. And it is very important because it is the way that we can maximize the potential for statistical analysis in the shortest time, just like what Alex has just presented in the GE investigation. And then we can give a more timely feedback to the contributors continuously and then review and improve. So after COVID and long COVID, what will be the next? We want to really hear from you, homeopaths around the world, to give us some advice on what to do next. Maybe menopause, maybe otitis media, or other pathologies. And we hope there will be more interaction between the users, the homeopaths, and the designers. And so we are organizing regular webinars, which are free for all homeopaths around the world. And you can register it through this website, or you can just Google clinical webinar, then you will get into this link. And the next one, the coming one, would be in January the 13th. The speaker would be Dr. Alex Tournier, and at that time, he will be reporting the lessons to learn from comparing the data between different countries. And yeah, we hope to see you there. Before we end our presentation, we really want to give our special thanks to the LMHI for the generous support of the project, so that we can many different kind of statistical analysis will be possible from this kind of data collection. And we also want to thank other supporters like ECH, ECCH, ICH, and the HRI. And there are plenty of national coordinators and members of the scientific committee that has made significant contribution. And at the end, we would like to thank CILSO for their generous support.
Thank you.
And
Thank you
thank you very much, and thank you for your
Thank
attention.
you very much.
Thank you very much, Dr. Alexander Luis and Ioane, for your wonderful informative presentation. Now, genus epidemicus is a historical word in homeopathy. It has a history, and your hard work will make it more relevant in the modern times today. So we look forward to so many questions coming up. And from your talk, we could see that you are doing really a very detailed and hard work, which includes statistics, mathematics, and so many calculations. So keep it up and be prepared for questions at the end of the session. Thank you very much.
Thank you very much.
Our next speaker is Dr. Rajan Shankaran from Mumbai, India, and he will be talking about homeopathy as an adjuvant to standard treatment protocol in management of coronavirus infections. A very, very important topic, clinical, but it concerns us all. And when we hear this from a speaker like Dr. Rajan Shankaran, you can know how informative it will be. A randomized, placebo-controlled, open-level study. So over to Dr. Rajan, please.
Yeah. I'll share my screen. Thank you, Dr. Parikh. So I want to speak about this study that we did. And I have to confess that it is my first attempt at doing clinical research. And the reason that I wanted to do this was, first of all, COVID was a very, very important subject or topic in the world at that time and even now. But I just want to share with, something from my heart with all of you esteemed people. Dr. Parikh is there, Dr. Manchanda is there, Dr. Cataldi is there, Dr. Anil Khurana is there. I want to share something, and that is, we know that homeopathy is taking a beating all over the world and facing very, very strong criticism from different governments, different organizations, from the media. And the main accusation against homeopathy is that we do not have reliable, high standard clinical studies which establishes its effectiveness. Randomized controlled trial, especially of the double-blind variety, are the golden standard which are accepted. And I am totally new to this, so please educate me. But I am not sure how so much criticism can happen if we did really have those kind of studies available and published in peer-reviewed modern medical journals. I'm not sure that we really have it. Though we may say we have, but somehow I'm not sure about it. And therefore, if homeopathy needs to survive, and it definitely does, and we see its effectiveness in our practice every single day through grateful patients who have been healed of very difficult illnesses. And we have so many case reports. But you know very well that individual case reports are considered as anecdotal evidence and not really the high standard of research that is demanded that we can establish our validity. And it is for this reason that I wanted to undertake my first clinical research study. I want to say to you that in March and April last year, when I tried to do this, I faced a lot of challenges. The government of India, the health ministry, simply would not allow us to do this research. They would not allow us to go within 2 miles of any COVID case at that time. It is with the help of very, very big supporters of homeopathy in various fields that we somehow managed to get the first permission, and we did actually the first trial of any Ayush system of medicine in COVID. The second big challenge that we faced was, how do we get into hospitals? You see, the Ayush ministry can say you can do the trial. In fact, they issued a notification, trials can be done on Ayush medicines, but no hospital would let us in. And at that time, all COVID cases were in the hospital, including mild ones. So there was not a single patient we could see. How do we do research? So again, there was a lot of begging and, pleading to the authorities of hospitals. And we were refused in many places in Mumbai. Ultimately, a particular hospital in Pune, which is very prominent hospital called Ruby Hall Clinic, gave us the first ethical committee clearance to do this research. And that's how we started. And then we spread to totally 4 hospitals, tertiary care hospitals in Pune, in Maharashtra. Dr. Anil Khurana and CCRH did support us. They helped us with the protocol. They helped us with advice. In fact, they even gave us some, lessons in how to do research, and I'm grateful for that. And so that's how we did it. We had a protocol. So I was the principal investigator. We also included in this trial the modern medical doctors who were on the floor of the hospital, the in charge of the COVID wards. We included them as co-principal investigators. And I think this is a very, very important model on which our research needs to be done in future, because that really adds value to the authenticity of our trials when we do it in collaboration with modern medical doctors who are also open-minded. And we should go to them not with the idea that homeopathy works, but with the idea that we are here with an open mind to work with you, to study with you whether it works, and we want to do it in a very, very unprejudiced manner. So it received ethical clearances, and our objective of the trial was to see that given the same kind of standard care across both the arms, the homeopathically treated arm and the placebo arm, whether the homeopathic medicine makes a difference to the outcome of the disease in various parameters. And we took initially a sample size of 100, which was then expanded to 300. And we divided it into 2 groups, patients with homeopathic medicines and placebo. And even though it was supposed to be an open label trial, but we had very rigorous standards and we almost made it a double-blind study. What do I mean by that? We made sure that neither the patient nor the physician who was attending the patient knew whether the patient was receiving placebo or the treatment. Only I, as the principal investigator, who was not even in touch with the patient, had this knowledge of who is receiving what. We took mild cases and we took moderate cases. We had exclusion criteria. We didn't take severe and critical cases. We didn't take cases on ventilatory support. We didn't take immunocompromised cases. And we studied, the clinical recovery of the patient and the requirement of life support, intensive care unit admissions, and mortality across the two groups. So we studied, all the various parameters, the hemogram, the inflammatory markers, the oxygen requirement, the adverse events, etc., and we followed. As far as homeopathic treatment is concerned, we used the principle of individualization. We didn't choose any one remedy over the other. And what we found, and this is what I want to share with you in my experience with COVID. And besides this, of course, I treated several hundred cases also, was that there were three levels of symptoms. One was the symptoms of the pandemic. The second was symptoms of the acute. And the third was symptoms of constitutional remedy. And this principle that we saw in COVID is now really applicable in homeopathic practice. You see, for example, if you get an injury, arnica is a genus epidemicus for injury. It's a specific remedy. So sometimes you may need arnica. Sometimes you may need a, suppose the fellow gets injured and he gets frightened. You may need to give him aconite. And sometimes even in the injury, the person may present with his constitutional symptoms. And he says, I've got severe pain, but I have craving for ice cream. It is possible. So we have to select the remedy according to either the symptoms of the pandemic or the symptoms of the acute or the constitutional symptoms, whichever is presenting itself at that moment. And that is the approach that we used. I have a method which I use in my practice, which is a very right-brained approach to homeopathy. It is called the sensation method. So along with studying the symptoms, the rubrics, which is the conventional method, I also study the patient's experience or the sensation. And I put these two together in order to have a synergistic approach to the selection of the remedy. And this synergistic approach was used also. What are the symptoms of the pandemic? There was a loss of smell and taste and sudden great weakness. And also, if you remember, in the early stages, there was something known as a happy hypoxia, which means the patient's lungs could be massively involved and the patient had absolutely no discomfort. And suddenly he would collapse and die. This was the kind of characteristic that was coming across from China and from other countries. And I had a homeopathic colleague in Iran who studied many cases before COVID reached India. And from a study of these cases, I thought that the remedy could be camphora. And that's the one that I used also as a genus epidemicus, and also in cases where the mild symptoms would come, there would be relative lack of anxiety. You see, the moment somebody is diagnosed with COVID, the guy would usually go into panic, and that you could think of arsenic, for example. But if the person says, COVID, I got COVID, so what? Nothing happened. This person, I would give camphora. Or the extreme fear to be left alone. Sometimes people were pushed into COVID wards and they had become totally isolated from the world. And they felt, where am I? I'm being in some different planet altogether. So these symptoms indicated for me camphora. I'm giving you an illustrative case of a 34-year-old female whose father died of COVID. Her mother tested positive and she had a 6-year-old baby. Now remember, this was a time when COVID was a terror. I mean, if you had COVID, you were a leper, almost. We are talking about those times. And she had severe anxiety because nobody was willing to keep the daughter in their house, that because of this COVID history. And she says, you know, doctor, I want to kill myself and my daughter. At least this pain will stop. I want to anesthetize myself from this terrible situation. If I could kill myself, I would be free. I would be numb. And for me, this is, you know, when you look at the symptoms here, desire to kill, the forsaken feeling, the shrieking for help, the helplessness, and you can see camphora coming, and that was what she received. And for me, the idea of camphora is also the idea of anesthesia. It's a remedy in the plant kingdom, in the first subclass of the dicotyledons, that is very close to opium, that is very close to Nux moscata. And the experience of this first subclass remedies is the idea of anesthesia, want to withdraw and shut yourself in the world. For me, this experience needs to be present in order that I prescribe a remedy. The symptoms and the experience must match. So she was given camphora 1M, she did beautifully. Now, I don't need to tell you that acute remedies also came. Arsenic was definitely prominent, bryonia, gelsemium, whatever you have mentioned, they were all prescribed according to the symptoms of the acute. But in some cases, I found that even in the chronic, in the acute, you could see the constitutional symptoms. So as an example, one of my doctors, treating doctors, went into the hospital and he saw this 26-year-old male COVID patient, and he didn't even talk about COVID symptoms. He says, you know, doctor, I like martial arts. I mean, what are you talking? I mean, you are in a hospital with COVID and you are talking about that you train for 1 hour every day. I can make somebody stand on my abdomen. If I'm attacked by 5 people, I can handle it. If I get a robber, I can hit the robber. This is what he's talking in COVID. And for me, this is a very, very good indication that I have to give him his constitutional remedy. And what he also said locally was that he feels as if his intestines are in knots, as if they are tied up in knots. So this physical sensation, when you look in the reference works program, you can see that there are 12 remedies, but the most prominent of them is cuprum metallicum. And when you repertorize his case, you know, and you see that his main experience is the experience that he has to defend himself through martial arts or other, you know, things against attacks. This comes in the periodic table. In the 4th row of the periodic table, remedies like ferrum, cuprum, and even later on arsenicum. And therefore, he got the remedy cuprum, with which he did very well. So what I'm trying to indicate is that in COVID, we use 3 approaches: symptoms of pandemic, symptoms of acute, or symptoms of the constitution, whichever was presenting itself most prominently at that time. And this approach we have now adopted in our practice as a broader understanding of homeopathic practice itself. I've given a list of the top remedies like bryonia, arsenic, pulsatilla, camphor, etc., etc. You can see, and these are common knowledge. And we have shown the prescription category. Camphora was given in 18, acute was given in 70, constitution was given in 60 cases. So you can see roughly what is the proportion of these 3 that we used. And I want to now just go over the results of the analysis. And here you can see the 300 was segregated into homeopathic group and placebo group. And all the standard medications, comorbidities of each case, age, gender, etc. were considered as variables. And the statistical study that was done was a multivariate study that took into account all of these variables in getting the result. So everything was taken into account, and it was also seen that in the beginning, the 2 groups were very, very similar in composition. But here we can see the multivariate analysis for mortality. You can see that in the treatment group, the mortality was so much less, significantly less, and the p-value was 0.01. Also, in terms of the ICU requirement, we can see that the ICU requirement in the treatment group was also significantly less, with a p-value of 0.042. Similarly, the need for ventilators was significantly lower in the treatment group at 0.046. So we found, in short, we found that, and a little bit more, we also studied the cough, we studied the shortness of breath, fatigue, we studied the inflammatory markers. And what is interesting here, that all of this was lower in the treatment group as compared with the control group. However, after a multivariate analysis, the difference was not statistically significant. From this, I understood that if we want to see a statistically significant difference in all of these parameters, we probably needed a much larger sample size. But what was definitely established was that the outcome in terms of mortality, ICU requirement, and ventilatory support requirement was significantly less. In fact, the mortality in the treatment group was 1/6 of what was in the placebo group. So if there was 1 death or 2 deaths in the treatment group, there were 12 deaths in the placebo group. This was roughly what it was. So the trial demonstrated a significant decrease in mortality, ICU admission, and the need for ventilatory support as compared to the placebo group. So what is the idea for me to present this? I feel, number one, the need for more clinical studies of really, really high value, of high standard. And next time that I would do it, I wouldn't even call it an open label study. I would straight away do a double blind study. Number one, this is very, very important because that is the gold standard. Number two, I think it is very important that the trial was conducted in allopathic hospitals with allopathic doctors as the co-PI. And this shows not only it validates and authenticates the study, but shows an integrated study and a cooperative approach, which I think that we should all support and encourage, because we don't want to live in exclusion and isolation. We want to work integrated with healthcare. And I think also, yes, I want to mention certain challenges. Certain challenges is to find open-minded hospitals and modern medical practitioners who are willing to work with you in interdisciplinary studies. Number two, that even if the practitioners are open-minded, the hospitals should also be open-minded enough to allow the ethical committee, and the hospital management should be involved. Thirdly, creating the need for a team of homeopaths to work, the need for funds, and the need for research organizations. So here, I would say, in short, a need for unity among homeopaths. I think many times we are a divided house. I am not sure at all that we tackle this pandemic together. I think many voices, many conflicting voices, lack of mutual consultation, and I'm including myself as one of the accused. So it's not an accusation, but an introspection. That did we really come together? Did we really face it together? And also, I think that can we at least learn from this and in future collaborate in a very serious way, you know, putting aside individual differences, political considerations, organizational considerations, etc. Can we come together? You know, homeopathy at this point is at a turning point. You know, it will either be validated or it will go down. And can we, as the current people responsible for it, come together, collaborate? And you know, the Central Council of Research in Homeopathy and the Ayush Ministry are very, very powerful resources for us also. And we should kind of come together and even suggest to the ministry, if possible. In India, we have such a good atmosphere of openness and governmental support, whether we can rope in leading institutions like the AIMS or other modern medic to conduct. And we should not be afraid. We should do the research. There should be no fear, you know. We at least, you see, you know, I want to make a confession here. I have two sons, and they are about 25 and 22, and they are graduates from Yale University. And they have seen the effects of homeopathy from their childhood. But they say, you know, Papa, homeopathy will not survive if you don't do this research, and if you don't do clinical studies really openly and unprejudiced and under the observation of people who are even critical to you. You know, there's no point we doing some research and patting our own back. We need to go to people who are critical and do it under their nose. And he says, unless you do that, you are going to suffer a severe crisis of credibility. So I want to make that thing, that can we do this together really? And I am willing to put whatever I have into this. I can put aside my practice, I can put aside everything else and just do this, because this is very, very, very vital for homeopathy to go forward and be recognized for its true value. So that's the appeal that I want to make. And I'm giving my email ID here for anybody who wants to be in touch with me and collaborate or whatever you want to do. You see, we should come together and we should decide for ourselves, yes, we want this. And if we do that, then I think we have a bright future, because our science is great, but its greatness has to be validated by clinical studies. So if I have said anything offensive or wrong, please forgive me, but this comes from a very good intention and with great respect for all your work and all your contributions. Thank you so much.
Thank you, Dr. Shankaran, for such a informative talk. And this talk has been really from your heart, I know. You talked so much from your inside of your heart. Talking about problems in doing research work in homeopathy, this is a ground reality which you said. And we must harmonize, we must coordinate, we must have an integrative approach. That is what is the need of the hour. Second, we cannot survive without clinical work. And you know it now, for so many years, I'm just doing clinical work. So we cannot survive without it. Nobody is going to recognize us today without a clinical work. Principles of homeopathy, as you rightly said, individualization stands supreme. And so you talked about the constitutional prescribing. We will be talking during the question and hours at the end of this session. And we need clinical studies with modern parameters, inflammatory markers, as you rightly said, D-dimer, CRP, seroferritin, that would show us in which direction we are moving. So thank you very much for your informative talk, and we will keep working in this direction. Thank you.
Thank you.
Our next speaker is Dr. Lex Rutten. Dr. Lex Rutten. Yeah. Yes. You are welcome. And I'm here. You are welcome. And he will be talking about homeopathic experiences, worldwide communication and experiments. Data collections and clinical poolings are very important, and we look forward to your informative talk. Dr. Rattan, please.
I thank you for this opportunity to present to you a project that was initiated from the LMHI and was soon joined by the American Institute of Homöopathie, the Ärztegemeinschaft für Klassische Homöopathie in Germany and Austria, the ECH, and the Directorate of Ayush Government of NCT and India. This was a project that was initiated to see if we could use this once in a century opportunity to learn from each other and to try to improve homeopathy as a method. And what we saw is in March 2020, we saw several things, many patients, many doctors who wanted to participate, to do something. But we also saw many opinions, different opinions about the genus epidemicus. And that especially is a bit difficult if we want to present homeopathy as a consistent method. How can it be that there are so many opinions about the genus epidemicus, one remedy for this disease? So we had to see what went on, how could we improve this? So what? How
Lex,
do we?
Sorry to interrupt you, Lex. We can't
Sorry?
see your slides. We are seeing your PowerPoint, but I think you're not sharing. We can see your the PowerPoint program, but not your slides as you're sharing them.
That's strange.
Try again. Maybe try sharing it again.
Can you see the program now?
Yeah, we can see your PowerPoint, the program itself.
And now?
No, we just see the same.
Good.
I think I did this before, but okay. So you are now seeing an overwhelming situation in March 2020. Is it right? Yes? Okay. So many patients, many doctors willing to do something, and but also many opinions about genus epidemicus. There were dozens of genus epidemicus medicines proposed, and this is a problem when we want to show homeopathy as a consistent method. So well, now something happened here.
Just single click on your screen.
Yes, but now it doesn't work. So we would like to present homeopathy as a consistent, reproducible, and scientific method. And so we do not want to claim any effectiveness at the moment, but we want to see what the cases tell us. And so we have to realize, just as Sankaran told us, we have opportunities and threats. So homeopathy is based on clinical experience. So we do not have to understand the virus. We have clinical data, and we can use the clinical data in the past to handle this disease. But unfortunately, this experience is so far not systematically recorded and in the same fashion by all practitioners. On the other hand, practitioners are used to describe cases, but they do not describe them sufficiently unique, unanimous. And also the experience is laid down in Materia Medica and repertory, but this repertory Materia Medica are over 100 years old, and they haven't not changed essentially, especially not in the light of modern statistics. And as Sankaran mentioned, practitioners are used to exchange experience, but they exchange their own experience as if it were the truth. And they are insufficiently aware of the fact that much of your experience is due to mere chance. And once you have experienced something, you are a bit prejudiced about the next case. There's some bias. So it's very important that practitioners realize that there is bias and that is producing much conflicts. So about the repertory, what is a repertory entry? Repertory entry exists, for instance, when a doctor has treated a patient with bryonia, wonderful results, and that patient had a fatigue. So anyone should agree that bryonia should be in the repertory rubric fatigue. But we have millions of cases at the moment. And what happens if we don't count them? For instance, this doctor that's had his first experience with fatigue and bryonia will prescribe bryonia in the next case of fatigue. And we do not know if fatigue is in 30% of the bryonia cases or in 60% of the bryonia cases. And that makes a difference. So what we see if we are discussing the genus epidemicus of COVID-19, we refer to the repertory and we show repertorizations, and we can make many different repertorizations based on different rubrics that we can choose for the same diseases. And if we make a repertorization of these COVID symptoms, we see mostly very common symptoms, and common symptoms are accompanied with large repertory rubrics. And in large repertory rubrics, we know that the most prescribed medicines are in mostly every rubric. And therefore, we see more than 50 medicines having all COVID symptoms in all cases, in all rubrics. And well, we have to start to count. So if we start counting, we know more things, and we know what's happening and why. So we counted the cases in by more than 100 doctors, and what you see here is a representation of 1,161 cases. And if we look at the symptom fatigue, we see fatigue in 127 bryonia cases and 59 gelsemium cases. This makes that many doctors say, well, I have seen bryonia cases with fatigue. I've seen many bryonia cases in fatigue. So we tend to think that bryonia is more important in cases of fatigue than gelsemium. However, if we count these cases also, we see that bryonia is prescribed 4 times more than gelsemium. And in that light, we should look at the fact that we see twice as much fatigue case in bryonia than in gelsemium. That is merely caused by the fact that bryonia is much more prescribed than gelsemium. And this is generally acknowledged as a problem of the repertory. The repertory is based on absolute occurrence, and statistics tell us that this can be misleading, especially for medicines that are frequently used. And we all know that there is a problem with large rubrics with medicines that are frequently used. There is another system, and it is, I think it's intuitive and understandable that we should use the relative occurrence, so the prevalence of a symptom. And as it happens, there is a statistical term, likelihood ratio, that says that you have to compare the prevalence of the symptom in a particular population, like bryonia, with the prevalence in the remainder of the population. And the interesting thing is that this likelihood ratio is the essential point of Bayes' theorem. Bayes theorem is used in all over the world, and especially in diagnostics in medicine, but also by insurance companies when calculating the insurance risk, and in most expert systems. And this likelihood ratio is the pivoting point for a homeopathic symptom. So it says that if the likelihood ratio is larger than 1, so the prevalence in the bryonia population of fatigue is larger than in the remainder of the population, then the chance increases that bryonia will work. So that fatigue indicates bryonia. This is what we have to do, and we see what we did in fact with this data collection program is we try to achieve a more scientific system for the repertory. First of all, we standardize the symptoms. So fatigue can have many similar expressions like prostration, weakness, etc. We should use all fatigue for this thing that we see in this disease, and then we can count them. The next step is that we do not use the absolute occurrence, but the relative occurrence. And if we do that, we see exactly the opposite of what we saw when we used the absolute occurrence. So we see that fatigue is more prominent in gelsemia than in bryonia. This, however, is not directly clear enough. If we use the scientific notation of likelihood ratio, we see that fatigue is an indication for gelsemia because likelihood ratio is above 1. And it is not an indication for bryonia because the likelihood ratio is below 1. And here we see a very clear distinction between the medicines mentioned here, very different from the existing repertory. This is one way as we progress in the past program, but we did more. It is very important that the data we gather are of high quality, because low quality data confusing and do not rectify the right conclusion. So we had several steps to make. We had to make this data consistent and exchangeable. So we had to use fatigue instead of the other terms, and we had to use them all. We had also the opportunity to do prospective research. So everybody had to check the symptom fatigue in predefined in a questionnaire. So the symptom was detected in every patient where it was. But we should realize the possibility of bias. If we have this doctor that had seen fatigue in a bryonia patient, tends to see fatigue in more bryonia patients. And we have to make the doctors participating in this data collection aware of this problem. Therefore, and especially India did a great job in that. You have to train the doctors that participate in the data collection. Furthermore, we analyzed all the data. We had about 2,500 cases, and we inspected every case for possible bias, but also we analyzed the data for groups that were different and indicating possible bias. We also compared our data collection with other data collection. And most of all, we get feedback to the participating doctors. This feedback was one of the most important things of this project. And we wanted to give them feedback as soon as possible and to improve the data collection during the process and during the pandemic to see a better treatment during the pandemic. We did this by a newsletter dispersed by the LMHI, and this newsletter started only 2 weeks after the starting of the data collection, end of March 2020. And after 2 weeks, we could already show the participants what we were doing and why. And we produced some 22 of these newsletters, and in the beginning, they were twice a week. And this gradually became less. But as soon as we could, we also presented the results, and to show the doctors, to help them to use the information they contributed to. This resulted in a Bayesian mini repertory. And the first mini repertory we produced was in the 1st of June 2020, 2.5 months after the start of the data collection. And what you see here is the Bayesian mini repertory that we have collected recently, based on 1161 cases, and covering 10 medicines and about 60 symptoms. So here we see 6 medicines, 7 symptoms, and the Bayesian repertory immediately shows which medicines are indicated by which symptoms. So we immediately see what likelihood ratios are above 1. So indicating cough indicates bryonia and camphora, and fatigue indicates camphora, gelsemium, and arsenicum, but not bryonia. And this way of representing the results in a Bayesian fashion gives a great separation between the different medicines. We see also that the likelihood ratios are rather low. Likelihood ratio below 2 do not permit us to base the prescription on one symptom. And that is what we all know. We know that with these common symptoms, we cannot prescribe on one of a common symptom. But if we combine the symptoms, then we have another much more clear picture. For instance, if we combine the symptoms muscle pain, dry cough, and headache, there are 3 symptoms that are, well, with rather low likelihood ratio, but combining them shows something more clear. But for this, we need an instrument which we made, and here you see the result. If we combine muscle, bone pain, dry cough, and fatigue, we see bryonia coming up as the one medicine out of 10 medicines that has this combination the most. This app is freely available at the internet address that is shown below. And this way we can use common symptoms to produce a reliable result that we could not have with the existing repertory. This, of course, is something that we can show to the public. And this is what we did. We chose the journal Homeopathy because it is indexed in PubMed, but also by the World Health Organization. And the advantage is also that homeopathy published a number of papers, and a few of them were related to our research that dealt with the same data and were comparable and complementary to each other. I showed just 8 papers, but there are other papers submitted but not yet published. There were more publications also in other journals by people who were also active in our data collections, and journals like also the American Journal of Homeopathy, the Allgemeine Homöopathische Zeitung, and Homeopathic Links. And this way we present, if we summarize what we did, so we organized a systematic standardized collection of cases. We trained our observers in quality of the data, so we could select 1,160 cases out of 2,500. We did a frequent data analysis to learn what these data told us, and we gave feedback to observers also to improve their work and also to improve their work in daily practice. We produced a scientific mini repertory and an algorithm that is recognized by all scientists at this moment. And we published this in public peer-reviewed journals, so it will be visible for all conventional colleagues too. That's in short, and rest one thing too, and that's difficult to thank all the people involved, because there were so many. I've shown some of them, and I hope that people are convinced that, well, we have more than 100 doctors contributing to this database. I would like to especially mention Tom Smedley. Tom Smedley is not a homeopathic physician, but and also not concerned in homeopathy, but he volunteered to make this app, and he did a very nice job with a very nice instrument that people could use. I can imagine that such an app would do very well with the set of homeopathic medicines like Mr. Treninek showed us. And this could be a system that is reproducible and recognizable for everybody who would try homeopathy. I thank you for your attention.
Thank you, Dr. Rattan, for such an informative talk. And I think this is need of the hour for homeopathy. Data collection and clinical pooling are very important, and they should go side by side. I have a feeling. And big data collection is very important. The aggregated experience of very many different practitioners is also very important. And our information should not only be pooled in a database, but should also be published in peer-reviewed journals, as you rightly said. I would request my colleague, Dr. Manchanda, to comment on your talk.
Thank you, Lex. We are actually thankful to Lex for mentoring all our team of Delhi government for these studies. And the studies that he has mentioned are going to be presented in this colloquium also. I would also like to inform all the delegates, those who are here, that these dialogue and these discussions on the quality of clinical trials, like Rajan has discussed and Alex has also shown the way it is required to be done. CCRH is also doing a wonderful job in terms of many trials are going on in different parts of India, supporting different state government, supporting non-government organization, and they themselves are also involved. And this is what is required in this COVID pandemic. And during this colloquium, we are going to discuss about more than 150 papers related to COVID, experiences of right starting from one single homeopath to different organizations. So these all are going to be presented in different halls, somewhere in the form of posters, in the form of clinical trials, and all these are there. So my request to all of you is please attend all these talks. And in hall number 4, we are going to have this in-depth discussion on the implications of big data, as well as what needs to be done in quality of clinical trials of different types. So these are just my comments on this. Overall, all the 4 presentations were excellent, and we have to move on with it, because now our next speaker is also here. That is Miss Rachel Robert, and she's going to discuss about what HRI is doing in research and what is the vision of HRI for doing research, because that can be the vision which many of us and many of our organizations can follow. And as rightly said by all of us, and this is the main motto of this colloquium, is we need to unite and pool all our resources where we have to have better research and better information in homeopathy. Thank you. And let us welcome Rachel Robert from HRI.
Thank you very much for that introduction. I really hope that you can see my screen okay, my slides okay. So I'm just going to test that. Yes, it seems.
Yeah, absolutely, it's okay. Go ahead.
Good. Fabulous. So yes, thank you very, very much for the opportunity to speak with you today, to share some updates from HRI. You've heard from Alex already what he's been up to with the wonderful Clifical project. Like many organizations, other plans we had for 2020 and 2021 just kind of went up in smoke, and we had to think again and regroup and really change where we put our focus from what we'd originally planned. So during those really difficult times, we have focused our time, energy, money in developing even more on the communication side, and also either creating brand new resources for the sector or improving existing resources. So the first thing to share with you was a shift in our communications in 2021. As you know, HRI has worked for over 10 years to get the message out there that the existing evidence base on homeopathy is not consistent with it being a placebo effect. So that's a long-term project. But in 2021, we wanted to shift the emphasis a little bit. We felt like until that point, we might have been sort of focusing on justifying our position, whereas we wanted to start questioning those who are taking the opposite view. For people who criticize homeopathy, we wanted to start saying, actually, I think you need to explain that position because that's not our experience of this evidence base. We also wanted to highlight that often the people who are critical of homeopathy have very little knowledge either of the evidence base or even of homeopathy itself. And in particular, you might see people in positions of authority, perhaps in the mainstream media, who are being critical of homeopathy and are sort of presented as experts. But in fact, they are experts in other fields. They are not experts in homeopathy. So we wanted to really focus on that kind of line in 2021 of why have you taken this position? What research have you read? And really sort of change the conversation a little bit. So the biggest task we did with this aim was creating a clip. I think it was around March this year. Scientists say homeopathy is not just a placebo. So if you haven't seen this clip, I'd urge you to have a little look. It's still on the homepage of the HRI website. Of course, it's only a few minutes long. And it's really trying to say that people who are saying homeopathy is placebo either don't know the evidence base, or maybe they are quoting flawed research, either not knowing it's flawed, or even worse, of course, sometimes perhaps they do know it's flawed research and they are still quoting it. So this is really a chance to get the real experts out there saying what's their experience of the research, and you'll recognize, I'm sure, many familiar faces on that clip. Another area we've put some attention this year is our researcher directory. So this is the homepage of our website. Down there on the left-hand side is the researcher directory that I don't think enough people know about. So it's my chance today to raise a bit of awareness. This directory has actually been on the website from day one back in 2014, but it didn't really take off. And part of that was because it was created on a very limited budget and it was never quite right. So we took the opportunity to revisit this and we really broke it down and rebuilt it with our tech guys. And the main purpose of this is to really help people collaborate more. There are times when you're really looking for somebody with a particular area of expertise. It might be something as simple as asking them one quick question to do with the physics of a paper or stats or provings or anything. You just want an expert to talk to. or it might be something much more formal, like putting a team together for new research. Now, we all know ResearchGate is a fabulous resource. LinkedIn, for those who like it, can often give you a solution here, but sometimes you just need a bit more than that, something more specific. So we'd really encourage people to sign up to this specific directory on the HRI website. We've made it even easier to join. There's a little form that you fill in. The minimum criteria to be accepted is just to have one paper published on homeopathy in a peer-reviewed journal. So that form comes to HRI. We do a sort of quality check to check that people are who they say they are. And if all is well, you go onto the directory. The big improvement we've made is that you can now update your profile yourself. The first version, it was too expensive to have that functionality, but that's now in place. So it's lovely now that this should never go out of date. People can go in anytime and change their entry to make sure that it's constantly up to date. So these are the kind of expertise we're looking for, and these are the filters you can use to find people. So it really is quite broad. It could be quite traditional expertise beyond our sector, or some kind of specialism within homeopathy research. Please spread the word. Please get people to use this. I know lots of people like RCCM in the past have said they really wanted to see this happen. So we've put it out there. Now we just hope that everybody will join it and use it. So another area we've been working on during these strange times is our homeopathy FAQs. This page, there is no scientific evidence homeopathy works, and our answer to that myth is still the most visited page on our website. And this is where we've been working with Dr. Robert Matthey to keep this data updated now. It had got old, it was static at 2014 for quite a long time. So we then invested in a big update, a 5-year update to make that pie chart current. And then we updated it again for 2020. So Robert has agreed to work with us now on an ongoing basis. Every spring, he will do the next year's data, and we will publish that on our website as soon as we can. One thing that's been lovely about this little project actually is been to give us some kind of insight into how our evidence base, just in this specific area, the double-blind RCTs, how is it shifting? Just in terms of this really kind of broad perspective of the balance of positive, negative, and inconclusive trials. And of course, when you commission something, you never know quite how it's going to turn out, but we were delighted to see that the evidence base is improving in all key areas that we'd be hoping for, except the average trials per condition. We still have this challenge. A lot of other speakers have already spoken about challenges today, and this is an ongoing challenge for the research sector. We have this highly scattered evidence base. We do need to start replicating trials and building data in certain areas to make it more compelling for certain people, and that hasn't yet changed. So I really hope that the day will come we do one of these updates, and perhaps that figure will also change. But a question I've had several times coming into the office since we published these updates was what are those 140 trials? Where can we find that data? Now, that is actually on the page. So here's the web page itself. And like everybody's websites, if it's underlined, it's a link. And that sentence there, if you click on that, it takes you straight through to a list of the studies that are in that pie chart. I appreciate it's not very obvious. We will look at improving that as soon as we can. But for now, I just wanted to take this opportunity to tell you that it's there. And if you click on that link, you get this page. Robert Matthey put this together for us. So every study has been assessed by him personally, and they are categorized in the positive, negative, and inconclusive categories. Another resource that I wanted to highlight today that already exists, but we're developing it more all the time, is simply our newsletters. This is the one that came out yesterday. These come out every quarter. So if you're not already signed up to our mailing list, please do so. We use it very carefully. We won't be sending out lots of rubbish to you, I promise. So once a quarter, this newsletter goes out, and I think there is perhaps a need to highlight this little area on the right-hand side. What we always include here is 2 or 3 links to recommended articles. And I think what's not being communicated well enough by us is what goes into that. There's a lot of effort and expertise that goes into the selection of those articles. So what it means is that every quarter, either Angelina Moseley for many years, or now our new researcher, Esther van der Werf, will be scouring all the literature, selecting 2 or 3 of the best studies that we think are worthy of being highlighted in this way. So of course, the quality has to be there or we are not interested. But then it might be about balancing a little bit the topics, basic research, fundamental research, clinical, veterinary, and so on. But if it's in there, we have pre-screened it, we have selected it for a reason. And importantly, after those newsletters go out, and you might see us then highlighting these topics on social media as well, they do get curated forever. So if you go to our resources area on our website and then click on recommended reading, this is where those same publications will live forever. So that section will have every article that we selected in that way going back for years. Another section to highlight for you today is the HRI publications. These take many forms. You have a filter on the right-hand side if you have an interest in a particular area. The obvious is peer-reviewed journals, articles. That could either be something we funded or just a member of the HRI team is one of the co-authors. Also, you'll see there, I mean, consultation submissions are not light reading, but you can see where we've engaged very formally with decision makers. But today I wanted to talk about the research in focus and synopses. These are 2 things we used to do up until about 2016, I think, and then we just got overwhelmed and we just didn't have the capacity to maintain that output. So the good news is we are now bringing back these 2 aspects of our work. Synopses are obvious. We, again, trying to take some of these particularly interesting studies and produce synopses that we can release and share for you all to use. But the research in focus is a little bit more than that. This was the last example that we did back in 2016. This is where we are particularly interested in a piece of research for some reason. It's really noteworthy. So what we try to do is take some of these sometimes very complex topics, synthesize them into just a 2-page A4 PDF. Sometimes we don't manage 2 pages. It has to be a little longer, but we always strive for 2 pages max. Very simple English so that it can be understood by anybody whilst maintaining the accuracy of the science, which is another challenge. And the idea is that this creates these PDFs that everybody can download, print out and use or email to people, whether it's a meeting you've got or you're just trying to educate people, even to pass on to your patients and so on. So that was always the concept behind these. So all the ones we've done in the past are all on the website, but we're very excited to have restarted that work again recently. The only other thing we do with this branding of HRI Research in Focus articles is if we have just done a conference, that edition, the next edition would be a simplified conference report. So technically the last one we did was 2019. But I'm really pleased to say we finally did a fresh one that was published yesterday, focusing on that fantastic observational study that was conducted in France. And that caught our attention again because it was recently critiqued at a very high level by an independent researcher in a peer-reviewed journal, which has really highlighted that this is absolutely top quality observational data with really great insights. It's very useful for everybody. Another section of the website was created since Monday this week. Monday to yesterday, we have just put in place, it's a small section, but we just felt it was really needed. The first page of external resources points to research organizations. So this is where you can go for really a huge amount of useful information from many of our colleagues in other organizations, such as the most obvious ones, of course, Jury, Visson, CCRH, and so on. The next page that we've just created is reporting guidelines. If you're thinking of doing new research, getting involved, or even just want to understand how quality is maintained and improved in new research, this is the place to go. And in particular here, the first 2 that we're highlighting are very recent publications that were orchestrated by our colleagues at Visson. And assessment tools, self-explanatory. These are a little bit older, but we wanted them to be here because it's really quite something that we have these very specialist tools created by homeopathy researchers for homeopathy researchers to use. Moving on a little bit to what you can expect from HRI in 2022. FAQs are as well used as ever, now in 12 languages, but you can see from this slide that our focus over the last few years has been on translation, purely at the request of various homeopathic communities who came to us saying, please, we really want these in our native language. And this has been fabulous working with people in all these countries to create these resources for them. But that meant we couldn't also update them. It would have been too difficult to update and translate at the same time. So again, these were done in 2014, showing their age a little bit now. So the time has come to do no more translation. The focus is now on updating. This has already started. We are working on the text, but it is going to be a big job. So it is going to go over into 2022. So really looking forward to refreshing that section of the website. Lots of people, of course, are in touch all the time asking what is happening in Australia. The Ombudsman investigation, believe it or not, is still ongoing since 2016. We're on our third investigator now. The most recent investigator took over the case around October, November last year. She's a very interesting woman to work with. We've had much more cooperation and collaboration with her than we had with previous investigators. And it's always difficult to know what to say because it's a legal case that's ongoing. But what I can say is that despite many false alarms of being told we're getting a verdict, then we don't. She is telling us now that she's winding up her investigation now, and she is looking to move to verdict in the early months of next year, was her exact words, the early months of next year. So we shall see. I used to put it in bold on my calendar. Now I think I do the digital equivalent of pencil because we've had several false alarms, but I would think that she's going to be true to her word on that. The other big aspect of the work in Australia revolves around the new Australian reports, for want of a better expression. Their formal name is the NHMRC Natural Therapy Reviews 2019 to 20, because this was pre-COVID and it all got stalled by COVID, of course, but that's still the name that they're using. And the only thing to really say here is that many people you can see listed on this slide and organisations have all played their part to try to ensure that the next Australian report is far more rigorous and robust and transparent and hopefully accurate than the one we had in 2015. But all we can do, of course, is provide official input when we're asked for it. So HRI and Jerry Dendrinos at the AHA have been providing official input to this for a very long time. Dr. David Levy in Australia is a member of one of the oversight committees, and Dr. Robert Van Hasselen was recruited by the Australian government to officially be a peer reviewer on the protocol. So it is moving. I think the last I heard was that they were aiming for publication in December 2022, and they're around the protocol, drafting the protocol stage. So that's going through various rounds of peer review and changes to get the protocol finalized. So it's happening right now, but it did, of course, get delayed. And the historic bit on this slide, the second section of the slide, is from last October last year. It was just a chance for me to say thank you again to every single organisation on this list who helped us respond to a ridiculous time frame. We had 2 to 3 weeks to send the Australian government all the evidence we thought should be reviewed in that review, which was insane. So the only way HRI could respond was we reached out and we divided the work up into sections, and each organisation took on a section, and we zipped it all together and turned it into a submission that officially went from every one of these organisations. So that was really, really a pleasure to work with everybody on that, and to perhaps send a signal to Australia that there is a really significant research sector for homeopathy around the world that is interested in this and contributing. In terms of new research, moving on, you'll be aware, I'm sure, that we had the exciting news that Alex has now moved to Switzerland to be part of the EKIM team at the University of Bern with Stefan Baumgartner. And the bit of Alex's work that HRI is funding, it's just one project that he's doing there, is the basophil degranulation experiments that are being kind of stripped back and rebuilt by Alex and his team. So that is really exciting work. You'll be aware that this is already one of the most stable basic research experimental models we have. But I gather that the idea is to take everything that Alex and Stefan and their colleagues have learned from the extensive systematic review they did in the last few years, looking at every fundamental research study done, what worked, what doesn't work, what could be improved, and so on. So they can bring the very latest knowledge and very latest techniques to this quite old now experimental model. So it's a rebuilding of this technique, which will be very exciting indeed. So other active projects, primary research is not the focus of HRI, but we're very proud to support what we can. And as well as Alex's work, we are also continuing to support Stephen Cartwright with his essential work on solvatochromic dyes. In the clinical area, you might be aware of the work of Dr. Philippa Fibert, who we have supported from day one, back in the days with a case series originally for her master's in ADHD, and then progressing on to a feasibility study, all going brilliantly. You can see from the interim analysis there that she got a great response for individualized homeopathy and a pragmatic RCT model, but COVID happened, more challenges happened, and it stalled. The exciting news is for us that it was looking like we might be able to reactivate that project shortly and possibly get it through to the complete RCT that was always the intention from the beginning. And Angelina Mosley, one of our core team, has been working away on an Arnica systematic review. HRI is co-funding that, again, stalled during COVID, but starting to pick up again now. The other updates for you briefly is just to let you know kind of what's going on inside HRI. We were really thrilled to have Professor Ashley Ross join us on our Board of Trustees this year. Many of you will know Ashley already, and I hope the reason we wanted him is obvious. Brilliant brain and bringing expertise that we were lacking, specifically world-class expertise in provings. There is virtually no provings material on our website, let alone anything else we do, and that is not deliberate. It is just something that's happened. We haven't ventured into that arena, and we really want to. We've always wanted to. Much easier to do that now we have someone like Ashley Ross on board. So we're really looking forward to doing more on the proving side of things. Just to mention, the management team is unchanged. I put this on there because some people, we got some messages when Alex moved to Switzerland and joined EKIM, were kind of worried that this changed something for HRI. So it's just to reassure you, nothing has changed on that front. Some of you will be aware Alex has always had other roles, very important roles, and HRI has been something he's done in addition to that, whether it was back in the early days when he worked at Cancer Research UK, right through to now while he's working partially for EKIM at Burns. So nothing has changed on that front. We have the exciting news that we've had additions to our core team. 1st of September this year, Dr. Esther van der Werf joined us. First time we've ever had a full-time researcher as part of the staff, which is fantastic news for us. Esther will be known to many of you. She comes with a fantastic background and expertise in CAM research generally, with a focus on AMR and women's health. She's now rapidly getting up to speed with the specifics of the homeopathy research world. So we're really looking forward to what she's going to bring to HRI. And personally, I was particularly happy to welcome Jackie Johnson, who is now my admin assistant and also is our new company secretary. So it's been great to expand HRI slightly and get a bit more capacity and help in the day-to-day running of things. Somebody asked me the other day, how many people work at HRI again? And for years, I think right back to 2015 in Rome, if you added everybody's time together, it was the equivalent of 3 full-time people. As of the 1st of September this year, we've finally made it to the equivalent of 4 full-time people. So there's Christopher Connolly is full-time communications, I'm full-time, Esther's full-time, everybody else is part-time, and together we make 4. So that's who's behind what we do. The next thing to mention, of course, is conferences. We really, really miss conferences, I have to say. It doesn't feel right that we weren't able to do our usual conference in June 2021, which would have been the natural time for us. Like everybody else, we've faced the challenges of live-to-live events. So what we've chosen to do next year is a one-day event online because travel restrictions are still very complicated for many people. It's not a conference as such, I would say, but if you look on the website now, you'll already see we have a fabulous keynote presentation lined up with Dr. Menachem Oberbaum and Anil Khurana from CCRH. Great talk that we're looking forward to there. And we actually have the rest of the speakers all lined up. We just haven't published the program yet. So looking forward to publishing that early next year. But we hope That will give everybody a nice little top up of another dose of high caliber research presentations, really focusing on the collaborative work that's gone on around the globe and how when we have been working together, as Rajan talked about, we are really starting to get far more impressive results and more impact because we're combining our expertise and resources. So I look forward to hosting that event. And the intention right now is to go back to our normal live full-scale conference in June 2023. It feels a long way away right now, but I am sure that it will be there before we know it. So the last thing for me is only to wish you happy Christmas and happy holidays from all of us at HRI. And thank you very, very much indeed for your attention.
Thank you very much, Dr. Roberts. Research updates from HRI are well known for promoting high quality of research in homeopathy. We appreciate the efforts, the sincere and the honest efforts of HRI and being constantly done against all odds. We appreciate the efforts again for promoting scientific homeopathy. And this is being done worldwide in spite of many challenges. Now, this is an eye-opener for many of us. Many of us don't know what really HRI is doing. So thank you so much for your efforts. It's a hard work, but at the end, it gives you a satisfaction, which is very important. So thank you very much, all the speakers. Before we come for our final comments, I would request Dr. Manchanda for his comments, and then I will be winding up. I think most of the questions have been answered by the speakers. If some question remain unanswered, please let us know. Over to Dr. Manchanda.
Before I say, are there any questions from our coordinator side, for moderator side? Any questions on the chat box if they have collected for any of the speaker?
No, sir, all the questions have been answered by the speakers.
Okay, thank you. So friends, we had very good session. All the 4 speakers presented nice work. And as I discussed that what is required in this colloquium is that we need to have a lot of deliberations, a lot of discussions. Even now, thousands of people have joined as attendee and our delegates. They are getting inspired by the work that is being done in different parts of the world. Now coming back to the just one line about all the 5 speakers, CCRH has already given a very, very comprehensive view about several trials that have already been completed and some of the studies, basic studies that are still going on. Some have already been published and rest are going to be published. And many of these are going to be presented in this colloquium. So I request all of you, please attend it. Alex has given a dimension that how this Cliffy-Call can be used in a modern day when lot of ideas are there from different parts of the world. If we use web-based platform like Cliffy-Call, it's really going to help us in creating you can say, a united voice in homeopathy about genus epidemicus. But if it is not, at least we can say in different regions, there can be a different genus epidemicus that needs to be explored and further verified by doing high quality field trials. And this is what we have done in Delhi government. And that is also going to be presented as a separate session, separate paper during this colloquium. Rajan has really changed from the earlier philosophical ideas to the randomized control trial. My compliments to him, and I had occasion to work with him in this high quality, another randomized double-blind controlled trial also, where we compared camphora with arsenic album, with Brineia, and with placebo, with 20,000 data, and that is also being analyzed. So my request is that we all have to come together and see that there is no alternative to high quality research. And Lex, I have already told you that he has been mentoring us, Delhi government officers, to how to have unbiased data collection. And this is what we are going to present separately also. And thank you, Rachel Robert, for showing us all the resources that HRI has created for the young researchers on their website. I'm sure that many of the PG student, postgraduate student, those who are already online and are hooked on, and they are going to see later on even the recording of this colloquium, will use those resources to improve their studies. And because what is going on in Indian schools, that we have 240 schools, many postgraduate students and MDs, but their resources are not being used on every time on high quality work. So if we know the tools, if we know how we can do it, within those resources, we can do that high quality work and with impactful publication. So thank you very much for all for joining, and over to Alok.
Thank you, Dr. Manchanda, for your summing up and talking about so much this COVID infection. In fact, you have been doing a lot of work on this, I know, and you are also the brain behind this colloquium. And I really applaud the efforts made by him. Now, coming back to COVID-19, all our speakers are very learned, experienced speakers. We really wish to keep hearing them. And I know it cannot be done in 30 minutes. You need hours and hours to listen to them. So the first information we got was a lot of work being done in scientific research, in giving homeopathy a footage. Now, coming back to the genus Epidemicus, it's a historical word for us. In fact, it's a boon for us. And people are now again recreating its scientificity. It's already a well-established word. Coming to COVID-19, acute and long COVID. See, we never talked about this in this session, but as Dr. Manchanda said, we will be talking about it in the other sessions. But I will just briefly talk about it. With acute COVID, we had minor symptoms with simple medicines. We had severe symptoms. Then we had very severe symptoms with mortality in the ICU. You see, everywhere homeopathy helped. Everywhere homeopathy helped. Even in the ICU, it helped with the oxygen need. It helped to revive the patient, but along with the medical support, necessary medical support. So as Dr. Rajan said, we must harmonize, we must coordinate. It is very important for us to know where the pathology is heading. Carbo-vegetable is good, but what pathology it is helping us? Bryonia, good, but what pathology it is helping us? Or what acute state arsenic is helping us? Now, coming to long COVID, friends, we are always at an advantage. In long COVID, we have an upper hand. And we must say this: patient having recovered from acute symptomatology, yet not recovered, yet with stressful symptoms, unwanted symptoms, not feeling well, still not COVID positive. Now, this long COVID is going to affect us for many years to come. And this is where homeopathy comes. And this is where the constitutional remedy comes. You see, this is where the miasmatic blockage comes. So we have to study the miasmatic blockage, the constitutional remedies, acute acting remedies, the clinical remedies. So it's a broad spectrum. COVID is not a small spectrum, it's a broad spectrum. So clinically, you have to study this. You have to study the clinical data. Then you have to study the laboratory parameters, inflammatory markers, infective markers, bleeding markers, blood clotting markers. We must all know about them. And we have remedies for them. Me as a clinician, working day and night on this. So I know the ground reality. Things are not so simple. Things are not so simple that you just give bryonia or you just give gelsemium. You should monitor all the parameters. To maintain the vitality of the patient is very important. And then long COVID is always the constitutional and the bigger remedies and the miasmatic blockage to be removed by the nosodes and like that. So with this, I thank you all for this very informative opening scientific session. And I think this opening scientific session has been very, very encouraging. And we look forward to the colloquium for the coming days. Thank you very much. Thank you very much.
Thank you. Thank you so much to our honorable chairpersons, our esteemed speakers, and all the delegates who have participated in the discussion and have asked questions. I can still see one question which is not answered. If anybody would like to take that question.
I think it is comment, not question.
Okay. Okay. Thank you. Thank you so much. Thank you so much, everyone, for this. Hope you have a great day, great night, great evening in whichever part of the world you are. And we are hoping for a wonderful and insightful colloquium from LMHI 2021. Thank you so much, everyone, for joining. We'll see you soon. Till then, bye-bye.
But we can have just one photograph.
Yes,
group
one
photograph of the panelists.
Extremely sorry. Yes, everybody, please, I would request all our esteemed guests, speakers, panelists, whosoever is present as a panelist, to please turn on your camera.
And we can
put
also
a
announce
big
the
smile
next.
on your face.
We can also announce the next session when it's going to happen.
Yes, the next session, I would request, Doctor, that we shall cut short on the coffee break and we shall continue the next session exactly at 9:30 p.m. IEST or 17 CET, as it would bring Hall-1 to time. Do I have the permission to do that? So if Dr. Rajkumar Manchanda, if you permit, we can start the next session sharp at 9:30.
Of course, it has to be. But let the IT team say whether they have taken their photographs of the group of the panel.
Yes, sir, done, sir.
Okay, thank you. Thank you, all the panelists. Now, after about a few minutes, next session will start. Thank you.
Thank you. See you all at 9:30 IST or 17 CET. Thank you so much for joining.